When do we get our exam grades back? Will it be today?
So we usually meet on Friday afternoons. So Friday evening, Saturday morning will be when the grades will be posted. We have to wait for everybody to test. And so some of the don't finish testing till the end of the week. And then we'll do
Sorry,
our,
we're behind technically in our mental health class, so we already got our grades for mental health because we were supposed to take it last week or something. I was just making sure.
Mhm.
Professor, I do have well, not exactly a question, but I wanted to see if you could go ahead and review or take up question 14, because it was a select all apply, but the way one of the options was worded, it was kind of like I wasn't sure, what exactly you were intending or looking for when you do the analysis.
Okay. Number 14. Okay.
Yes. And specifically, it was regarding the wording of the mandatory checkup.
I will look at it. Absolutely. All right. So I'll share my screen. I have PowerPoint. All right. So HESI, you guys have taken lots of HESIs up until this point. So just always remember your nursing process, your ADPI, right? Analysis, planning, implementation, evaluation. All right. So clinical judgment. Um, this to some of this, how many of you, when you do your NCLEX questions, look at your results and the areas that you scored lower on, or just the different areas in general? Okay, so these are some of the areas that you see, right, with your NCLEX questions, right? Recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, take action, and evaluating outcomes, right? So these are some of the things. And when you do your NCLEX questions and you submit your NCLEX questions, um, I know some of you probably, do really, some of you do really well in your NCLEX questions, and not, I don't know how many times it takes you to do them, right, to get the score that you're doing. But look back at your NCLEX questions that you do weekly, and look at the different areas, because these are some of the areas that you're going to see on your HESI, as well as when you take your NCLEX. Okay. So some of the other client needs categories that you'll see: safe and effective care, coordinated care, safety and infection control, your physiological adaptation, your psychological integrity, health promotion, reduction of risk. Um, so look at each one of these. Again, as you went through and you did your NCLEX questions this term, and these are some of the topics that you saw. And I'm going to stop sharing for a second. Oops, I'm going to hit the wrong button first. Um, can't find it. So when you're doing your NCLEX questions, what is safe and effective care? What are some things that you would see under safe and effective care?
Like urinary tract infections from the catheters.
Okay. And what are some just some techniques that we use to try to prevent those things.
Hand washing, I would say take them out when it's time to take them out. Don't prolong it, prolong the catheters.
Okay. Yeah, that's definitely one of them, right? We try not to use the catheters, right? And even things like making sure that you are providing the catheter care, right? Mariama, yes, absolutely. So two patient identifiers. Give me an example of two patient identifiers.
Name and date of birth.
Okay, name and date of birth. Okay. What else?
Scan the band.
Okay, scan the band if you have, right? If you have that ability to scan the band, right? You're going to scan the band. What are some other safety measures that we use?
Prevention of falls.
Okay, fall prevention is a huge one, right? For a lot of our patients. Um, what are some fall prevention measures?
Bed alarm.
Bed alarms, okay. What about coordinated care? What are some things that you would see under coordinated care?
Wouldn't there be like more so proper communication with all like health professionals, all different teams or specialties?
Okay, right, working with other members of the healthcare team, right? What about um your psychological integrity? So you've got you either had mental health or you're taking mental health, right? So what are, what are some issues that we look at?
Are you talking about like therapeutic communication and like de-escalation?
Mm-hmm.
And your therapeutic value, making sure they have a safe, non-judgmental environment.
Okay, right. So we're looking at emotional, mental, social well-being of our clients, right? So, it's dealing with everything psychological, right? Stress reduction, adaptation to, what's going on with them, right? So we see patients at their best days, we see them on their worst days. So how we are going to work, with the clients that way. And then, like you said, who was it? I think it was Jory, right? That said, working with different populations and de-escalation techniques. What about health promotion?
Can you repeat the question? I'm sorry.
What about health promotion? What are some client needs issues that you'll see with health promotion?
So like promoting like a healthy exercise routine to help like keep your heart healthy and your blood sugar in check and like make sure you're attending like proper screenings for like your blood pressure and blood sugar to make sure that you're within normal ranges. So I feel like health promotion is just mainly like preventative care.
Yes. So it's related to growth and development. It is your, preventing health issues, recognizing alterations in any change, any changes within them, It's also, like you said, other practices that promote and support optimal wellness. So, again, you take somebody that is sick or ill or newly diagnosed with a condition, or someone that has a chronic condition, what are some health promotion things that we can do for them? And then we go into safety or safe, effective care, your safety infection control. We kind of talked about that. But safe and effective care, this is also prioritization of patients, right? Who are who are you going to see first? How do you prioritize which client or which patient you're going to see first when you come into work? How do you make that decision?
Who has the most life-threatening condition at the time?
Okay, so acute before chronic, right? So let's say if you have, let's say you have a diabetic with a blood sugar of 500, and you have trying to think of another one, um, a client who's 2 days post-op that has some pain in their incision, which client is going to be the first one that you are going to see?
The guy with hyperglycemia.
Right, the guy with the hyperglycemia, right? Because 2 days post-op, right, having some pain in their incision is going to be something that, I mean, not that it's kind of a normal expectation, right? So, making sure that we can understand like who, how to prioritize those patients. And then the other one is reduction of risk. So reduction of risk, what are some things that you may see for reduction of risk?
Hand hygiene.
Say that again, I'm sorry.
Hand hygiene.
Okay, hand hygiene, that would fall under, right, infection control as well. What else?
Ensure like fall risk patients have like the grippy socks.
Okay, right, grippy socks. Yes. And it also could be, when we talk, what about medication? What are some reduction of risk that we would take with medication administration?
The 3 med checks.
Okay, your 3 checks, your, checking for allergies, right? Making sure that we're not giving them something that they're potentially allergic to. So these are, just think of, I know it's a lot of information, right? But think of these things as you're going through each one of these categories. So some of the nursing concepts that you may see on HESI, professional behaviors. What are give me some professional behaviors. Think about going into, your going into work one morning or dealing with your patients, professional behaviors.
Promoting a good attitude.
All right, promoting a good attitude, that definitely could be having a good attitude, right? When you come into work. Okay, what else?
Introducing yourself when you enter a room rather and like asking, is it okay if I do your wound dressing right now? And like giving them an option, not just forcing them to do something.
Okay. All right. So communicating with your client, right? Working out an effective schedule. What about think of things that you've seen and things that have, you've experienced, whether it's in school, whether it's in your clinical environments, right? What are some things that you see, right? Interaction
Maintaining,
with, say that again, ma'am.
maintaining the client's privacy.
Okay, maintaining clients' privacy, right? Making sure that, we are communicating appropriately, that we provide not only a safe environment for our clients, but for other members of the healthcare team, right? Maintaining that professionalism, at work. Um, Uncivil behaviors, whether it's from nurse to nurse, nurse to CNA, nurse to provider, right? They create hostile environment. So always keep that level of professionalism. What do we do during our assessment process?
Gather data,
Okay, what kind of data are we gathering?
Objective or quantitative data,
Okay,
and
so
subjective as well.
we're collecting subjective and objective data. So what is subjective data?
Into what the client or the patient says or expresses.
Okay, it's what the client tells us, what their caregiver tells us. What is objective data?
That would be something that's measurable, whether it be like their vitals, their labs,
Okay, and it's
even
something
something we
that,
see too, bruises, skin breakdown.
okay, so, see, touch, right, feel, smell, our senses. What do we do with all of our assessment data that we collect?
We analyze it.
Okay, we analyze the information, we organize the information, and from that information, right, we get with the RN, we write our nursing diagnoses, right, and then we go into our planning process. And what's our planning process? What do we do during the planning process?
Come up with a care plan.
So we identify goals for our clients, right? What do we want our client to be able to achieve, whether it's short term or long term? And what should goals be?
Realistic and obtainable.
Right. Realistic and attainable, and they need to have a time frame, right? So whatever the time frame is. And then from our planning, we develop our interventions, right? So what are interventions?
The care that you're going to give to make the patient better.
Okay, so the interventions are what we are going to do and what the client is going to do, right, in order to help them achieve their goals that we have set, correct? And then we go into the evaluation process. And during the evaluation process, right, we evaluate all the interventions. Did the client meet their goals? What happens if the client did not meet their goals?
You go back in and reassess and plan all over again.
Right. You go back and you reassess, you, make new goals if necessary. And you kind of go from there. What's clinical judgment?
Critical thinking.
Okay, critical thinking. So how do we use our clinical judgment?
based off of
Determine-
experience and the research evidence, nursing
Okay.
process.
So it's using evidence-based practice or evidence and knowledge, right? The knowledge that you've gained through nursing school, as well as, well, we're going to just use nursing school, right? It involves critical thinking and decision making. And these are all skills that we use to formulate that nursing process, assess, diagnose, plan, implement, and evaluating patient care, right? So this is recognizing cues. Recognizing cues is identifying that patient, their relevant patient data. It's your symptoms, your vital signs, your patient history. Analyzing cues, interpreting and, taking all that data to understand what's going on with your clients. You're prioritizing. This is all part of your clinical judgment. That's determining the most likely causes of the patient's symptoms, right? And that's how we prioritize our patients' interventions. Generating solutions, developing and considering different treatment options based on evidence and clinical guidelines. And then we take action, right? So we're going to take those interventions and we're going to put them into play. And we're going to monitor our clients' progress through those interventions. And then we go back in and we evaluate. So we have to have good clinical judgment for safe and effective care, as well as safe and effective nursing practice. It allows us as nurses, as future nurses, to anticipate patient problems, make better informed decisions, as well as adapt care to individual patient needs. And so, nursing school is not the end of your learning, okay? You're going to continue to learn. And so, this requires you to continue to learn. You're going to get more clinical, judgment experience as you go out into practice. But that evidence-based practice is going to be key in that situation. So supervision of UAPs and scope of practice, right? This is where your State Board of Nursing, right, comes into play, that Nurse Practice Act. You need to know your Nurse Practice Act, what you can and cannot do in your state of practice, as well as any UAPs that you are supervising. Okay, and that scope of practice, though very similar across the board, is going to vary from state to state, right? So you have to know what they can and cannot do under that Nurse Practice Act, as well as your facilities, policies, and procedures and their job descriptions, right? Safety, concepts of safety. We talked a little bit about those. Collaboration is working with, other members of the healthcare team. We know teaching is a huge part. Who does the initial teaching?
RN.
RN.
The RN does the initial teaching, right? And then we go back and we reinforce, right? Continuously reinforce. Every client moment is a teaching moment, right? So that is, we want to make sure that we are doing that. All right. So let's go. We'll start again with safe and effective healthcare provider. Or safe and effective environment. Sorry. What are contact precautions? What do we use contact precautions for?
Keeping us safe from patients that have like diseases and illnesses that we can contact through touching them or their bodily fluids, things like that.
Okay. Contact precautions, think of, I don't know, almost anything. What do we use specifically for airborne? What's airborne precautions used for?
Like N95, use it for TB.
Tuberculosis. Okay. What would we use droplet precautions for?
Pneumonia.
Okay. We know hand hygiene is the number one way to prevent the spread of infection. What do we do if a client refuses care?
X, Y.
Ask why, and then provide education, right? So I don't want my antibiotic because it makes me nauseous. Okay. So, ask them why they don't want it, and then provide the education. Can we ultimately make them do something they don't want to do?
No.
No, right? And then what do we do after they refuse care and we provide education?
Document it.
Document it. Thank you. All right, HIPAA and confidentiality, right? We know that we don't give out information to people that call up on the phone. Hey, I'm Mrs. Jones's neighbor. I was just calling to see how she's doing today, right? Can I tell her how Mrs. Jones is doing today?
No,
No, right? Unless I have what?
Permission. Consent.
Okay. This is, minimizing your screen. This is not this is like not walking away from your computer and leaving the information open, right, for other people or patients to see. It's not talking about patients, in the elevator, in the cafeteria. What do we do if somebody says they feel like their privacy has been um what's a word violated?
Don't they have to see like a compliance person?
Right, you can give them the information either for the compliance officer, the privacy officer, the organization, and they're going to do an investigation. Also, this is about client mobility, how to use cane, how to wheelchair, ambulation, right? How to transfer from bed to chair, chair to bed. What are advanced directives?
Is that like the living will and I forgot the other one. The door of power of attorney.
Okay. Advanced directives. This is if, something happens to me and I can no longer make decisions for myself. Okay. Then this is what I want to have done. This is what I don't want. I don't want tubes. I don't want IVs. I don't want feeding tubes, those kind of things, right? While you're, in your right mind, you can lay out what you want in the event something should happen. What is an ambiguous prescription? Let's put it this way. What are the parts of a prescription that must be present in order for you to give a medication?
The order.
The doctor prescribing it, the dosage.
their name on it.
Patient's name, patient's date of birth, the date of the prescription, the full medication order, right? The medication, the route, the dose, how often they're going to get that medication, right? And the doctor has to sign it. What do we do if we don't have all the right parts of a medication order?
Verify
They
with the
get it in
provider.
order.
Yeah, we don't give
The
it.
physician.
Very good. We don't give the order. Okay. We make sure that we get clarification on that order. So safe and effective care also is going to include medication administration. That's your 9 rights of medication administration. That's your 3 checks. It's making sure that you have everything that you need. You're going to check their allergies, right? You're going to use the 2 patient identifiers. If a medication doesn't have the route, can we change the route? Let's say you have a patient that has a peg tube. Okay, and the medication is written as oral. Can you just crush it and put it in the peg tube?
No,
No, very good. We have to get clarification of that order, right? It has to be, okay, so good job. Um, Client preferences. You know, we talked a lot about cultural competence and cultural care. So, you know, we can take, some of their cultural preference, right? Incorporate them into their into their care, right? We can put those into their plan of care as long as it is safe, right? It's not going to be dangerous to them, and that it's not going to interrupt the care of other people, other clients on the unit. Positioning, safe and effective care as well, follow-up and evaluation, medication errors. What do we do if there's a medication error? What's our first priority?
Check the patient.
Assess our patient, right? Doesn't matter if it's a vitamin C, okay, or if it's, you know, digoxin, okay? Regardless of the medication, our first responsibility is to our client to make sure that they are safe. And then we report it, correct? All right. Medication teaching is another part of safe and effective care, right? Making sure they know what their medication is, how they need to take the medication, how often they're supposed to take the medication, and as well as any side effects or adverse effects that need to be reported should they take their medication, right? So think of um digoxin. Okay, digoxin is one of the drugs that we use for heart failure, right? Making sure that they know the signs and symptoms of dig toxicity, that they know that they're going to have periodic blood work, right, in order to check their therapeutic drug levels, right? What foods should they avoid, right, when taking certain medications? Are there beverages that they should avoid? Right? Think of MAOIs, right? No tyramine containing foods. Safe and effective care is also your skin integrity, right? Turning and repositioning, you know, making sure that we're keeping that skin clean, dry, and intact. It also involves conflict resolution. And so this is some of what Jory was saying, right? Working with, you know, patients, it's, you know, not every patient is going to agree with what we're doing, right? We're not going to agree with each patient as well. So de-escalation techniques, right? How to resolve conflicts. Management of care. This is your prioritization of care. Again, who do we see first, right? We get our assignment for the day, you get reports. Who do we see? Who are the ones that we're going to go see first, right? It's always acute before chronic, right? And then you follow your ABCs. Continuity of care is another concept under here. What's continuity of care? So the important thing with continuity of care is that our patients are receiving consistent and comprehensive care, right, throughout their medical experience, whether it's, you know, in the hospital as a transition maybe to a long-term care, right, or even back out into the community. It helps to improve patient outcomes. It helps to reduce costs, reduce complications. It also increases patient satisfaction, right? If they have good continuity of care, they're more likely to be satisfied. It also, like I said, helps to recognize complications quickly so that we can address them effectively. What is assignment? What's assignment versus delegation?
The assignment is like who your patient load is. The delegation is like what you can hand off to somebody to help you with your assignment.
Normal duties.
Right. So your assignment is your normal duties, right? That is like you come into work and you know that you're gonna have to do A, B, C, and D, right? And then delegation is what we can pass off to, I hate to say pass off, but right, it is a task that
Share
we
with.
can give to somebody else, right?
Mhm.
Generally they're tasks, right? And so what are the 5 rights of delegation? Or yeah.
Right person, right communication, right direction,
Right task.
Right task,
right
right patient.
supervision, and evaluation.
Awesome. So what must our patient be in order to delegate a task?
Stable.
Stable, right? So that means we have to go lay eyes on on our client, right? To make sure that they are stable prior to delegating a task to a UAP. What are some tasks that we can delegate?
Feeding, helping patients get dressed, ambulating to the bathroom.
Bathing,
Some
vital signs.
vitals.
Very good. Um, what are some tasks that cannot be delegated to a UAP?
Anything that requires nursing judgment.
Nursing judgment, sterile procedures, right? Anything that's not within their scope of practice. All right. What's the best communication technique that we can use when we are talking, let's say, with a provider?
S-bar.
SBAR, right? Because SBAR is going to give all that information, right, to the provider that we need to give. Other parts of management of care, client and staff refusal of care. So, staff, can you refuse to take care of a client?
Yes.
Yes, if it's out of your scope of practice.
Okay, if it's out of your scope of practice, okay. I never thought about that, but yes, I guess, yeah, absolutely. If it is outside of your scope of practice, can't talk. W- What if,
Also, if the patient is abusive, because I walked away from an abusive resident.
okay, an abusive resident, what do we have to do if we are refusing to care for our patient?
Make sure that the care is covered.
Make sure the care is covered. Is it always possible to refuse to care for a patient? No, right? So there's a lot of different things that can go into that. The clients have to be taken care of, right? As nurses, that is our responsibility. That is kind of, when we go to work, that is the expectation is that we're going to care for the clients. If there is a client for whatever reason that you do not wish to care for, that is something that you have to go to your supervisor, your manager, and discuss that situation to see if care can be reassigned. Not always a guarantee, okay? And I don't know who works in long-term care. I know some of you work in long-term care. Has anybody been fired by a client before in long-term care? Right? Sometimes they fire us too, right? They don't like us, and that does, I've had it happen with CNAs, I've had it happen with nurses. And so reassigning, the client to another CNA or another nurse. And I explained to the clients, it's not always a guarantee at some point, right? It may not be another nurse. That may be the only nurse that is there. And we need to come to some sort of an understanding. What do we do if there's a client complaint?
Report it.
So one of the first things that we want to try to do is see if we can address the situation effectively, right? And then, yes, if we cannot address the situation effectively, then we are going to go to our supervisor, our manager, right? And, go from there. Making sure that you have the proper equipment, right? If you don't have the right size blood pressure cuff, we're not going to get an accurate reading. Make sure that you know how to use the blood pressure cuff. Management of care also is your ambulation, your CPR. What's missed care?
Like something you should have did that you didn't.
Something that you should have done that you didn't do. Okay. What do we do in that situation?
Don't you have to file like a report with the charge nurse or something like that? I can't remember the name.
So it's any care that's admitted, it's or delayed, whether it's partly or completely. And so, we can, maybe you didn't, you missed their I'm trying to think, maybe there was a missed medication, a missed treatment, or, something along those lines. And it is a huge safety concern when we look at missed care, because it could lead to potential complications, right? Or worsening of conditions. What should we do in that situation? Report it, right? Report it, whether it's to your supervisor, your manager, and then we need to get that care taken care of. What does the Nurse Practice Act tell us?
What our scope of practice is as a nurse within that state.
Right, it tells us what we can and what we can't do. It also, right, for every aspect of nursing. So it's RNs, LPNs, it's your CNAs, your nurse practitioners, it's going to tell you exactly what you can and cannot do. That's the overarching for the state. Your organization, whether it's a hospital, a long-term care facility, a clinic, or wherever, right? They can minimize what you can and cannot do, but they cannot go above that Nurse Practice Act, right? Colleague reporting. What do we do if we have a coworker that we suspect is using diverting medications or using medications while at work or comes into work intoxicated? Do we ignore it?
No,
No.
you tell the charge nurse.
Charge nurse.
Right. Why is it a concern?
They could harm the patient.
They can harm their patient. They can get hurt too. It's a dual concern. Not only can they harm a patient, but they can harm themselves. Medication errors and documentations, we talked about those. What are sentinel events?
When
When
you
a
harm
patient
the patient,
dies,
or when the patient dies, you harm the patient to just a great extent to where they're incapacitated or maimed or whatever, or if they die, right?
Okay, so it's a serious, unexpected occurrence that can result in death or permanent harm, or even severe temporary harm. So, what are some examples of sentinel events?
A medication error that ended up in a fatality.
Okay, a medication error that led to a death. Okay, or even serious injury. What else?
Neglect. Neglect like not feeding someone, which happened actually to my husband.
Oh, wow. That would, I don't, I'm not sure that would fall under a sentinel event. That would be more like negligence or abuse.
Well, actually, the first hospital that happened, no IV, no food, no drink. Second place was the rehab, left the tray across the room, bed bound. Third hospital, he had to be rushed back. No IV, no food. And so I mentioned to the doctor, hey, he's not dying of COVID. He's dying of malnutrition, and dehydration. He said, stop all tests, get this man hydrated, nurse. He died the next morning.
Oh
So
my
that's
God,
why I
I'm so
threw that in
sorry.
there.
Oh, wow. Okay. So more that, yeah, I still then you definitely neglect. Absolutely, definitely neglect. But it's, wrong site surgeries, right? They go in for a right knee replacement and they get a left knee replacement. That's a sentinel event. Death or a serious injury related to a fall. So think of your fall risk patients falling out of bed, break a hip, they have to have surgery. It could, and I've actually had a coworker that had this happen. Retention of foreign objects after surgery. So one of my former coworkers actually had gastric bypass long time ago, and they left a clamp in her, and she kept complaining of abdominal pain and after abdominal pain, and finally they did, I think it was like a CT scan or something, and they realized that there was a clamp still inside, and they had to go in and take it. So these things still do happen. Sentinel events have to be reported. And then we do the investigation, right? What can we do to prevent that from, what are some causes for that event that occurred? What are some things that we can do to prevent that from happening? Client assignment, we talked about client assignments. Talked about scope of practice. So you're working in a hospital. Does that mean that you can access any client record that you want to in that hospital?
No.
Whose client records can you access?
The patient that you're working on.
The patient that you're assigned to, right? So if somebody famous comes into the emergency room and you hear about it through the grapevine, can you log in and check their record to see why they're in the emergency room?
No.
No. What's a Good Samaritan Act?
When you stop and help someone on the road, maybe has had an accident or someone falls in a parking lot or something.
Okay, you have stop and help somebody. And so what does it do for us?
Protects the nurse if something goes wrong while they're trying to help somebody outside of the hospital.
Okay, so it provides legal protection, right, from civil liability to anybody that stops to render aid, as long as what? And this is,
You're working inside your scope of practice.
you're working
Yeah.
within your scope of practice and your skill set, right? So we have to be careful, making sure that we are, working within our scope of practice. We're not doing something outside of our scope of practice and that we're not doing something that we cannot do, right? If you're not CPR certified, don't do CPR, right? That kind of thing. Phone prescriptions. How do you take a telephone order? What are some steps to taking a telephone order over the phone? I guess that was redundant, but
Writing down the order and then repeating it back to the provider for clarification.
okay, so writing
And
down the
also
order.
having a witness.
Okay, you can have a witness. Absolutely. What if the provider really talks and he said he wants clonidine 0.4 milligrams twice a day for 10 days? What do you
Ask
do?
them to repeat back.
Have them
Okay.
spell it out too.
Okay, have them spell out, especially if it's, some of those, I'm trying to think of some of the more hard to say or, some of those, think of those sound alike, look alike medications, right? You want to make sure that you get it. All right. So you have your HESI book, you have your NCLEX book, right? You have your practice questions. So talk a little bit more about this. One of the biggest, not one of the biggest, but one thing that I can say when you're reading your test questions, whether it's your exam questions, whether it's HESI, whether it's NCLEX, whatever, is I always say read the question and cover up the answers. Put your hand over the computer screen, and try to answer that question without looking at the answers, right? And then once you formulate that answer, then look at the answers and choose the one that closest resembles what what you suggest. Not always going to know exactly what you want to do, but you generally can have an idea of what the question is asking. Assess versus implement, right? So that's another big thing with reading questions. What is the question asking you to do? Is it something that you need to go assess, or is it something that you need to go do? And then Maslow. We all know who Abraham Maslow is. What are the basic needs of our patients?
Airway,
Providing,
circulation.
yeah.
Breathing, circulation, shelter, food.
Right. And so if those basic needs are met, right, it's going to cause some conflict within our clients in order to meet those, right? So what are some of the things that, think about that? What are the basic needs that we need to provide for our clients? And then we have spec, stable versus unstable, right? Potential versus real, expected versus unexpected, chronic versus acute. So, is it something that is, if you're looking at a question, I'm just trying to think of a question, but if you're thinking of a question, let me see, I can pull up question. I'm just pulling up any random question. All right, so let's see. The nurse is caring for a hospitalized client with a diagnosis of heart failure who suddenly complains of shortness of breath during activity. After assisting the client to bed and placing them in a high Fowler's position, what would be the next thing that we are going to do? Next immediate action. All right. So client is all of a sudden they have heart failure. They're complaining of shortness of breath. We put them back in bed. We put them in the high Fowler's position. And then what would be the next step? Would
Report it
we
to the nurse.
Take their pulse shots, their vitals.
get their vital signs?
Okay.
Right? Yeah. Get their vital signs first. Let's see what's going on, because even if you're going to report to a nurse, or even if you're going to report to a provider, what information, think of the SBAR, what information do we need before we go report, right? So definitely need to get some vital signs, and then do an assessment, check their respiratory status, check their cardiovascular status, and then, right, we can take that information, we can report that over to a charge nurse, to a provider. So we, listen to, look at those questions and pay attention to really what it's asking for. And then what are the expected outcomes, right? So if you provide an intervention for a client, right, you give a medication, whatever it is, what's the expectation of that? You know, what should occur once that intervention is provided, right? Other strategies, you know, visualize the client situation. Look at their vital signs, look at their labs. You know, a lot of the questions are going to give you that information. The first, remember, does not always mean an assessment. And that's, you know, something that we have to, you know, we have to look at too. And I know that the last question I gave you was an assessment, but it doesn't always mean an assessment question, right? And actions don't always mean that you have to implement something. So you have to be, you know, really look at the questions and determine, you know, what the question is really asking you to do. We talked about Maslow's already, the basic physiologic needs. So those physical needs are going to take priority over the psychosocial needs, right? And then safety and security is going to be another thing, right? So how do we provide for safe, effective care for our clients? Pain for HESI is usually considered psychosocial, so that's a little tip. So pain for pain with HESI is going to be psychosocial. And then we talked a little bit this, right? When we talked about prioritizing of care, who do we go see first? ABCs, airway, breathing, circulation, safety. Who's going to die first, right? Remember, acute before chronic, and then follow your ABCs. Recognizing expected and unexpected behaviors. To prove minimum competency, a beginner nurse must demonstrate ability to make appropriate nursing judgments. So you need to be able to recognize both expected as well as unexpected outcomes. And that allows us to evaluate whether or not their goals have been met. So what is the expected outcome of your action? You know, what is the best action for the expected outcome? Will it help or will it hurt? Is it desired? You know, and this is something that I was always told to as a nursing student. If I can only do one thing before I leave the room, what am I going to do? All right. And that's going to be based on whatever your, you know, what the status of your client. All right, so here's a question. Which client's complaint of loops? Which client's complaint of pain should the nurse respond to first? Bladder spasms after draining 1,000 mLs of urine. Flank pain partially relieved after passing a renal calculus. Bladder pain while receiving a continuous saline irrigant 2 hours after TERP. Or incisional pain on the 3rd day post-nephrectomy requesting a PRN oral pain med. Who are we going to see first?
B2, the flank pain.
Okay, flank pain partially relieved after passing a renal stone.
1.
Bladder spasms after draining 1,000 mLs of urine during insertion. So we have 1 and 2. Anybody else? So the answer is bladder pain while receiving a continuous saline irrigant 2 hours after a TERP procedure. Okay, so bladder spasms after draining 1,000 mLs of urine that is going to be expected, right? So put that Foley catheter in, we drain that urine, and it's a quick drain, right? It's very common for bladders to spasm. Flank pain partially relieved after passing a renal stone. Flank pain with kidney stones is very common. All right. May not initially go away. Maybe they had more than one stone. All right. So they may still have some flank pain. Incisional pain on the third day post nephrectomy, requesting a PRN, absolutely expected, right? But there's, during a continuous saline irrigant, they should not have bladder pain.
So, all right, that one's going off of like more so the expected versus the unexpected.
Correct.
So then when does, because I'm thinking like, I guess flank pain as far as renal calculi is some of the few exceptions for pain prioritizing over like psychosocial need, should you say. So like I know sickle cell, also there's like a few other ones where it's like there's that exception to the rule of pain not being psychosocial.
Mm-hmm.
So in what like situation, like how do I guess differentiate within the question itself if I'm looking at it as far as expected to unexpected versus the like the priority of pain to psychosocial, if that makes like any sense.
I'm not sure I understand your question.
Okay, because it's still like both of them are priority questions, so I was just trying to see like how not to mix that up or make sure, I pinpoint
So
that
yeah,
correctly.
I think I understand that part, but this is going back like more med-surg, like kind of just knowing like what should be expected when certain things are done. Um, so it is, I mean, flank pain with kidney stones is common, right? And so I passed one stone, there may be other stones, but the pain is going away. Okay. So
Um,
partially relieved, right? Whereas the bladder spasms after draining a Foley, that's completely expected, especially if we drain 1,000 mLs. Incisional pain, third day, they want a PRN. That's, kind of expected as well. So that's what I'm saying. Like those are expected pains. Expected things to happen. They should not have pain, with an irrigation. So that's something that we need to look at. TURP procedures they're invasive, but they're minimally invasive. Then very few complications that occur with them. But they definitely shouldn't have bladder pain. All right, the practical nurse is evaluating a new client's risk for osteoporosis who has recently moved into an assisted living community. Which task should the PN assign to the UAP? So we have a new client. We're evaluating a new client's risk for osteoporosis. What can we assign to the UAP?
One.
One,
So wait,
is it three?
Very good. You're going to take weekly height and weight measurements, right? Can they review a medical record to compare findings for disease history? Is that within a scope of practice for a UAP?
no,
Hope. Should they perform full range of motion of all extremities? As a
No.
no,
UAP?
they have osteoporosis, so their bones and stuff is weak.
Right, and so the nurse should do that initial assessment, correct?
Yes.
And inspect and palpate the client's vertebral column from neck to hip. Would that be something within their scope of practice?
No.
Okay. All right. So These are active listening. We talked about active listening, the beginning of the term, right? We have the restating, the clarifying, the reflecting, paraphrasing, minimal encouraging, silence, summarizing, and validating. Negative communication styles, right? Those are your why questions, your, oh, it's going to be all right, right? Your false reassurances, probing, judging, belittling. We don't give advice, right? Or we can give advice like maybe you should talk to your healthcare provider. I mean, that's good advice, right? We don't generally want to give healthcare advice. All right, so the practical nurse is observing a UAP, provide care for a client in an assisted living community. Which action by the UAP should the practical nurse determine is safe for the UAP to continue?
Two.
Two.
2.
2. Very good. Obtains vital signs for client who takes blood pressure medication. Good job. The practical nurse is emptying a client's urinary bedside drainage unit. Which component of the nursing process is the PN using?
Is it 2?
Implementation.
2.
Oops. Yep. Very good. All right. Which one of our clients should we see first? We have Harry, who is 88 years old, who had a bowel obstruction. He vomited 100 mLs of bile colored vomited 100 mLs that is bile covered, and NG2 was ordered. Naomi, 38, has appendicitis. Pain is 7 out of 10. Temperature is 102.7. Peter, who is 15, has Crohn's disease. He's having frequent watery stools and has a blood pressure of 95/50. And then Pam is 59. She's in liver failure. She's jaundiced and she's confused. Who are we going to see first?
Would it be Pam just from the confusion? Then Peter?
So Pam, then Peter,
Naomi.
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 Mm-hmm.
All
Yeah, I
right.
think Naomi is first.
Naomi is first, right? She has appendicitis with pain 7 out of
Can you
10.
give me her potty?
And her temperature is 102.7. Why do we want to see Naomi first?
Wait 2 seconds.
I thought when they still have pain, it's kind of, I mean,
She's
obviously
been
it's
waiting.
bad, but I thought you want them when they're not in pain is when you're more concerned.
Fever leads to
Because
infection.
that would mean like it ruptured.
Her appendicitis rupturing.
Fever potentially means that she is ruptured and now she is developing what?
Appendicitis.
An infection. Got it.
Peritonitis, right? So that could be that my gallbladder has now burst, right? And I'm going to be septic and develop peritonitis.
Got it.
Most common reasons a new grad loses his or her license, not that we want to throw this out there, but failure to notice or recognize, failure to act and respond, or failure to report and communicate. All right. So we make mistakes. Nurses make mistakes. Okay. So just remember that, but pay attention, right? Pay attention to, that assessment, you need to be able to recognize those, you need to be able to act and respond to changes in clients' conditions, and you need to be able to, if you don't know, report it. If it's
Does
something
that count during like orientation phase as well?
During the orientation phase, you will have somebody with you. Usually we'll have a preceptor or somebody that is orienting you that's going to guide you through that orientation process. But if you're unsure, report it. If you are unsure of something, go to your manager, your supervisor, your preceptor, right? And say, hey, I don't know if this is a concern, however, comma, this is what I'm gonna say, report it. And then, they can help you like work through the situation. But if you don't know, it's best to report because you don't want to miss something. We know our ethical principles of non-maleficence, beneficence, autonomy, fidelity, and justice, right? So non-maleficence, do no harm. Beneficence is do good. Autonomy is the free to choose, right? Privacy, fidelity is be true, and justice is being fair to all. The 4 elements that are needed to prove negligence, right? 1, that you had a duty to that client, that you had a breach of duty to that client, and that breach of duty led to damages. And so they have to be able to prove that in order to take you to court. So Mrs. Stone is recovering from pneumonia and has been receiving steroid and antibiotic therapy. She has an indwelling urinary catheter that was placed 4 days ago. Although being afebrile for 24 hours, this morning her temperature is 99.9 degrees Fahrenheit. What are your concerns?
I mean, isn't 99.9 isn't a fever though. So isn't she still technically afebrile?
It's an elevated temperature, right?
Oh,
If she's been afebrile, right, and now all of a sudden her temperature is up, that is a potential for concern. What are some other concerns?
Preventing infection, as she has she's on a steroid, which will suppress the immune system.
Okay,
And then she has the indwelling catheter.
okay. That increases the risk for infection, right? So what are 3 things you can delegate to a nursing assistant?
grabbing her temperature,
Okay, monitor her or take her temperature. What else?
emptying the Foley catheter bag,
Emptying the catheter bag. What else?
maybe getting like a ice pack or something for the fever, something like that. Cold washcloth.
A cool washcloth. What about providing catheter care? So
Um,
she's recovering from pneumonia. She's receiving steroids and antibiotics. The indwelling catheter was placed 4 hours ago, and now she has a temperature. All right. So those are some of the key things that we are looking for. You're absolutely right. Even though I'm on antibiotics, I'm still on steroids, right? And that's going to increase my risk for infection because it's going to suppress my immune system, which means that I could be developing another infection or a super infection, right? Which is one infection on top of the other. So ambulation, vital signs, bathing, emptying the Foley, repositioning, assisting with feeding. Those are just some general things that we would delegate. We do not delegate any assessment, communications with physicians, disease education reinforcement, medication administration, any sterile techniques. So what are some areas of education that we can reinforce with, I don't know why it popped up, but these are some areas that we're going to reinforce with Mrs. Stone concerning her pneumonia, right? Cough and deep breath, frequent rest breaks, use of her incentive spirometer, how to prevent disease transmission, making sure she takes her medications as directed, right? And that she is increasing her fluids.